Okay. Good evening, everyone, and welcome to the Health and Wellbeing Board, Wednesday, 21st of January, 2026. I will just go through some apologies for absence, and then if anyone can tell me any more that they're aware of, that would be great. We've got Tom Hurst from the Fire Service and Tony Tranter is substituting. Hello, Tony. Martin Kelly from CYC has sent apologies. Fiona Wiley from North Yorkshire Police has also sent apologies, and Lucy Brown, you're subbing for Claire Smith from York Hospital, is that correct? Thank you. Has anyone got any declarations of interest they'd like to make? No. Okay. So agenda item 3, the minutes of the meeting from the 19th of November. Has anybody got anything they'd like to raise about them? Any questions, concerns? Nope. Okay, thank you. I'll go ahead and sign those. So we have one speaker who has registered for this evening, and that is Flick Williams, who is going to speak remotely on agenda item number 7, and that's water fluoridation. And Flick, are you there?
Yes, good afternoon.
Good afternoon. I believe you don't want a 30-second warning, do you?
That's correct, thank you.
Okay, so whenever you're ready, that'd be great. Thank you.
Water fluoridation. First, a question. This board is being asked to support the principle, and leaders of councils in Yorkshire and the Humber asked to indicate their support to the Secretary of State. It is unclear to me whether there will be any further public consultation. If not, and the decision is effectively being taken here, why is there no human rights and equalities impact assessment to accompany it? I believe the issues are more complex than presented. First, the principle relating to human rights. Is universal dosing acceptable? The addition of what is effectively medication to the water supply, which is a necessity for human life, my body, my choice, is effectively overridden. Worldwide data on public consent to water fluoridation can be summarised as generally coming out at 2/3 in favour and 1/3 against. But of course, the answer you get depends very much on the question you ask. People are far more likely to agree with the statement, do you support adding fluoride to the water supply to prevent dental decay in children, than they are to agree to, do you support the addition of chemicals to the water supply for any other reason than ensuring water safety. This paper mentions Calgary, Canada, but not the growing number of territories that are now reversing previous decisions quite recently, including statewide in both Utah and Florida. Why is that? Campaigners against say that studies focus only on the impacts of dental health, not longer-term studies on neurotoxicity at population level, which are problematic to achieve owing to the inability to isolate fluoridation from other factors. In areas of naturally occurring high levels or fluoride dosing of the water supply, many doctors, following the precautionary principle, advise pregnant mothers to consume only bottled water owing to the unknown risk to fetal development during gestation. And then to the practical, there are a number of documented accidents regarding dosing at water treatment plants, resulting in hospitalisation and death of vulnerable people, particularly dialysis patients. This inevitably raises the question about trust in a privatised water company whose decision-making is profit-driven. Will water bills rise as a result? Yorkshire Water is now principally owned by foreign investors concentrated in Singapore, Hong Kong and Australia. Is the public health of the citizens of Yorkshire and the Humber their priority? Clearly not. And personally, I have no trust in a company that prioritises paying shareholders over upgrading ageing Victorian infrastructure to reduce the appalling level of leaks and waste, not to mention the unlawful discharge of untreated sewage polluting our rivers, lakes and coastal areas. In summary, is this not a sledgehammer to crack a nut with an unquantified level of risk when the solution is surely the topical use of fluoride instead? When public health uses the term safe and effective, it is now viewed very differently by citizens than it was prior to 2021. Thank you.
Thank you very much, Flick, and we will take those comments into account when we cover this at agenda item number 7. Thank you. So we move on now to agenda item number 5, which is going to be a presentation on the direction and purpose of York's neighbourhoods to inform health and wellbeing planning for the neighbourhood health reform. This is a really, really important agenda item for this time because we are looking at a part of the new duties for our Health and Wellbeing Board to publish neighbourhood plans and how we are going to be involved with this and our level of involvement. Peter, if you're going to introduce this and then hand over to Tori and Pauline. Thank you.
Absolutely. Thank you, Chair. Yeah, and the reason I'm introducing it, I guess, is to ground it in the work of this board particularly, and then Tori and Pauline are going to go into a lot more detail around what's in some slides that you have in your pack. And I would absolutely sort of echo Chair's comments just in terms of what's in it really is the front and centre of the 10-year health plan for England to get an NHS which is typically fairly centred around acute hospitals, working much more at neighbourhood level, and to get services which are from outside the NHS much more deeply integrated, embedded with the NHS. And I think it's a really timely alignment in York. I think this in some senses works better, or could work better in York than many other places. I think at the same time that the NHS was articulating and wanted to do these 3 shifts from analog to digital, from treatment to prevention, and from the hospital community, we were already in York having lots of conversations about our neighbourhoods and doing things on a neighbourhood level. So actually the 2 things have come together really nicely. And in a sense, I think the council and the NHS are probably just catching up with where communities in general have been for decades, in terms of actually in York, people very much do see themselves relating to various different parts of the city that don't necessarily mean coming into a city centre in order to receive services. And so I think in some senses we're just catching up with where our population has been for a very long time. The Health and Wellbeing Board, if we could go on to the next slide, is due to play really quite significant part within these changes. And as you can see, we're just here putting some excerpts in from a couple of pieces of national policy about the way that the board is going to be asked to draw up a neighbourhood health plan to influence the way this works out for our population. I think it's a really key role, but just to be really clear, it's not a role that doesn't come without a significant amount of support. And in fact, the infrastructure, the working groups, the workshops, the standing boards that are set up now around neighbourhood health in York are quite substantial. It might be that Tori and Pauline mentioned a few of them. There is an incredible amount of work that's going on outside of this meeting. I think our piece in it is about the steering of it, is about the governance. It's about the fact this is probably the only meeting where in public and in front of, you know, our sort of public democratically, we're really steering the agenda. So let's use this meeting wisely in that way to have those types of conversations. And I think I would finally just point to the fact that we've got a workshop coming up in a couple of months where I think we'll get back into detail about to what extent do we around the table shape this plan. We can't micromanage it. There's a lot of detail that needs to be worked out, but we also want to steer the agenda, and mindful that this is the group where we have that mix of officers working on things and politicians in their communities leading. So we absolutely want to have that democratic voice through the work of this board. The next 2 or 3 slides, I will really just summarise just to show that we've got, obviously, I think they are based on the JSNA. We have a lot of data around our health and wellbeing needs in the city, and we're rooting the neighbourhood work in that data. The Joint Strategic Needs Assessment is done at quite strategic level. So it will talk about, as you can see on our lovely Dahlgren and Whitehood rainbow diagram, the things which make health possible, all the way from the individual level things in the red circle to those wider determinants of health that come in the white. So we have been looking a lot at this data, looking a lot about how access to healthcare and access to things which create health are going to shape neighbourhood health. The next slide, I think, just summarises what we know about our population. And this is very high level, just the fact that our JSNA will tell us where the population is in terms of its level of deprivation, in terms of its ageing, in terms of its distinct demographics, but also where it's going. And in York, that's very important, because in York, with a signed off local plan, we know we're adding quite a significant number of people to our population. So we can't just build neighbourhoods for the York that we have in 2025. We have to build that model for the York that we'll have over the next 5 to 10 years. The next slide just again shows a little bit of what we know, particularly about life expectancy and poverty and some of the inequalities as well. And if neighbourhood health is going to do one thing, one would hope that it narrows that gap, and that is our strategic priority as a health and wellbeing board. And then I think the next slide, a final slide, is just to explain, when we say neighbourhoods, a diagram that many will have seen, but I don't want to assume all have seen, that we have made a decision as a community across voluntary, across our council and across the health system, that York fits into populations of around about 50,000. That's in line with the national model in the 10-year plan. So we're very mindful we need to make that a priority, but it also lines up with our 21 wards, and each of our wards fits into one of these 4 areas: north, east, west, and central. And this is just some very, very cursory information. There is far more that lies underneath that. In fact, there's a whole data pack for each of those being developed, just telling you a little bit, for instance, on this slide about, well, how many GP practices do we have? Do we have a mental health hub in this area? How many social houses do we have? So it's that type of intelligence that we're really starting to work into. And I'll hand over to Pauline and Tori, who are going to talk a lot more about some of that work on the ground.
Thank you, Peter. I'm Pauline Stutchfield, Director of Housing Communities, and I'm accompanied by Dr. Victoria Blake, or Tori, and it's actually on your, Tori's on your title there. Just to talk a bit about, between us, the direction for health as part of this model. But I want to start by saying that this is a multidisciplinary approach, even though the slides on this presentation do have a health focus, because you're the Health and Wellbeing Board. We are, as a local authority, designing all of our services to work within communities on an early intervention and prevention approach, so that we can work with people as early as possible and as locally as possible. And of course, it's not the first time that we're doing this. And aside from local area coordination that has been around for a long time now in York, we've got various models of integrated working already in place across the city. And we're getting very good at this. And it means that we don't have to reinvent the wheel. We've got some excellent practice already in the city. And when Tori was starting work with us as well, just prior to becoming place coach, I think you were impressed by the volume of work that we were already doing on this basis as part of the city, and doing some really positive targeted work with groups of residents across the city. And important that to say that this is an all-age model. So we've got SEND hubs, we've got family hubs, we've got frailty hubs, we've got mental health hubs in the city, all of which we're learning from. We've done some work exploring the roles of and the governance around the work that we're doing, so that we can actually start this work. We've already established neighbourhood partnership boards across the city in those 4 areas, and many services within the council have started planning their delivery of their services within those 4 areas. So we've already established these groups. They are interdisciplinary, and we are working with the voluntary and community sector on a piece of work around how they have a voice, they drive, that they're part of our response to being able to respond to some of the issues that affect neighbourhoods and wards. Importantly, the voice of lived experience is critical to that as well. They are now, they've already met once or twice. They're looking at the data within their wards, and this is data across the wider determinants of health, not just health data, to be able to target where their attention needs to focus on early. And if they can get on with some small stuff some great stuff, then they're encouraged to do that already. It's important that they set the strategy for the area. But then there's the integrated working that will take place to support the population and to support individuals as well in those complex cases that the data is telling us about. So we've agreed a consistent approach. We've agreed a set of principles, both at York Health and Care Collaborative and at Executive in the council, about the way we're going to work. The principles of highlighting, particularly around health, the way that we're going to do that using population health data. And I think Victoria's going to take over from me. Am I? Well, I'm taking this one. Okay. Obviously, the 10-year health plan is our driving force behind this. And of course, money is a key factor, and savings and being more efficient and using some of the tools that we've got around digital. However, this is not about the money. This is about doing the right things in the right place at the right time. And that in itself will make it possible for us to achieve healthy and sustainable communities, which is what this is all about. So I'm going to move on from there. That's fine.
So as Pauline introduced me, I'm Tori Blake. I'm a GP and I'm Director of Urgent Care for Nimbus Care, which is a multi-neighbourhood provider in York, made up of all of York's GP practices. But I'm here with my place coach for Neighbourhoods hat on, which is not about any one organisation. It's about coming together to do.
Could you move the microphone a little bit closer to you?
I can.
Thank you.
Is that better?
Yeah.
So the place coach role is not about one provider. It's about us all coming together to do what's right for York's residents. So I'm going to talk you through a little bit about the how. What does it mean practically? And most importantly, what does it mean for one of York's residents, and talk you through a case study. So we'll be taking a population health management approach, and this is about early intervention and prevention, as Pauline said. It's about focusing on what matters to people, and we'll be using data-driven methodology to identify residents who need a multi-agency approach to support them. And we'll work together across those agencies to better support people who the current system is failing through an all-age approach. So starting at the bottom of this slide, the residents who would benefit from a multi-agency support are those that historically haven't received the support that they need by one agency on their own. So we're going to organise ourselves into integrated neighbourhood teams. So that's a group of colleagues from different organisations that are working together to meet the needs of a person. And they're often complex, and it's the complexity of people's lives that mean that there isn't a one-size-fits-all approach. We need to really target what we're doing for people. And that's particularly true when people have got multiple conditions that affect their lives. So we want to address the wider determinants of health, as well as health inequalities. So this slide is an example of how a population could be understood using a population health management approach tool, such as the dashboard that we have available to us from the ICB. So this looks like a noisy slide, but let me talk you through it. So if we think about those residents living in our most deprived areas with long-term respiratory conditions, we can look at people through the lens of how old they are. So take adults, for example, and those living in our most deprived areas. We can also look at residents who have got particular long-term conditions like COPD or asthma. And then we can look at other indicators that allow us to really hone our focus on cohorts of people who have particular needs. And that's going to help us organise ourselves around those individuals. So finally, I just wanted to talk you through a story, a real resident story. So Caroline has been out of work for many years due to multiple complex needs. She's housebound and struggling with social isolation. And her granddaughter's been looking after her, but she's gone to university. So there's a breakdown in care. Caroline's unable to leave her room, and her nutrition is suffering because she's not been getting the meals that she needs, so living off sandwiches and things. So the drop-off in care has caused social isolation, which has affected her mental health. And she once had a thriving social life, but now she's struggling. So Caroline was someone we identified as someone who would benefit from this multi-agency approach. And a proactive social prescriber met with her and has made a plan to transform how things are going for Caroline. So the social prescriber visited her, built a trusted relationship, and asked her what matters to her. They've offered a COPD review at the practice, so she's got the right medication. They've generated a package of care for her. She's got some home adaptations. She's had an eye test at home, which has changed her falls risk. And she's had some support from the mental health practitioner at her local GP surgery. And she's been connected into some community groups, so she's now not as isolated as she was. So that trusted relationship changes people's lives, and that's what we're trying to achieve. And hand back to Pauline. Thank you.
Thank you, Tori. So what have we got in place? As I mentioned earlier, the principles and frameworks that give us our infrastructure to move forward with this across, and I have to say and stress, health and the council and our partners, which we've not seen anywhere else, really gives us the success factors that we need to move forward in partnership. We've said that our neighbourhood panels are in place, our boards are in place, and importantly, across both health and care and the council, we've got work streams of work already underway. We've got task and finish groups within the health and care partnership, and we've got work streams within our transformation programme within the council. We're establishing our governance structures, including our co-production and voluntary and community sector organisations, and we've established the groups that are then going to deliver the rest of the detail moving forward around how we govern ourselves, communication, engagement and co-production. And we've absolutely agreed that these are different things and all need attention. How our workforce is going to work together, how we're going to refer between us, and how are we going to sort of look at our systems and make sure that we can share information. So digital and data is all important. We've talked about taking a data approach to what we're doing, an evidence-based approach to what we're doing, and we're working with the universities on evaluation and research of the work that we're doing as well. We're continuing to build relationships and share learning at York Health and Care Collaborative, and each of the areas report back at each meeting on the work that they're doing. I think it's quite incredible the pace that they're working at. And we've reviewed our combined data with neighbourhood insight packs, and this is important because this is where the wards fit in. Underneath those 4 areas, as Peter said, there are the wards within the administrative area of the council, and further data and detail is applied in terms of those wards, and that's where you can start to identify the areas of priority within the larger neighbourhoods. So over to Peter about next steps for the Health and Wellbeing Board.
Thanks, Pauline. Well, yeah, just to conclude then, we were potentially hoping we might be coming to the meeting having had some national guidance that would really clearly articulate exactly how health and wellbeing boards are meant to be forming their neighbourhood plans, in particular sort of a date by which it needs to be done by and what it needs to look like. We haven't quite got there yet in terms of the guidance. We are expecting that to land in the next few weeks. So I think what we do have is that initial guidance that boards will need to offer a bit of leadership. We have a session in March, which is a bit of a workshop which the LGA facilitated for us. But one of the key lines of inquiry at the workshop is, how do we lead neighbourhood health well, and how do we fulfil that neighbourhood plan as a board? And so I think really welcome people's input and discussion on that this evening. The suggestion and the steer is that the timescales for that may not fall within what we have within diary, so we may need to do some of that through a bit of an email process, but we certainly will look to free up time on agenda to be talking about this over the next couple of sessions of the Health and Wellbeing Board, and we will make people aware when that guidance comes out of exactly what it's asking of us as a board. I think there are a number of other governance considerations about the way this works with what we have at the moment around the Better Care Fund, and the fact that I think those two things are going to be quite substantially linked into the future, and the way in which as a board we relate to the changing integrated care board and the way that that relates. So quite a lot of unknowns in there which we can't necessarily answer tonight, but I think it's useful to have those questions, those conversations at this stage, and then move forward. Thanks, Chair.
Thank you, Peter. Thank you, Tori and Pauline as well. Thank you. I think it's really clear that neighbourhood health is such a massive priority countrywide. But what I've realised recently from going to other cities is we're in a really strong position with our model and quite a long way forwards from other cities. I've mentioned it and other places have been like, we're getting on with that. But I think we're quite a long way with that. And regarding the neighbourhood plans coming to us, I think it's really important to discuss kind of how involved we want to be with this and how much we want to see this. Obviously, we're signing off the plans, so it's how involved do we want to be. Thank you. Would anyone like to make any comments on this? Oh, Councillor Webb?
Thanks very much. It's just a question really on Caroline's story that's mentioned in the document. I think that's a really good example of how we support our residents, and it's a great piece of work, right? How does that link in necessarily to sort of the stuff on the previous couple of pages around the sort of the neighbourhood model? What about York's neighbourhood model is leading to a different outcome for Caroline? It's a little bit unclear, because I look at what's happened there with the sort of the social prescribing, for example, and think, well, that's good work, but would that be going on anyway? So how does the neighbourhood model make a difference here?
Yeah, thank you.
Thank you. It's a great question, and we have to reflect on where we are now and where we want to be, because where we are now is working in organisations that are focused around delivering a particular service in a particular way, and where we're not necessarily at, and where we want to get to, and where we're very far on getting to, is working together around the needs of an individual. And that's a very different thing, because what that means is that each organisation needs to organise themselves around a geography so that they're looking at a particular group of residents. And finding particular groups of residents that have things in common that colleagues can come together and discuss and make plans for is the way we need to work. That looks different to different organisations just looking after their individual residents or patients.
Thank you. And if I can just follow up on that, I suppose the key thing in terms of organising how different organisations, different bits of this partnership sort of work together better. Part of that is around funding, of course, and organising how that funding goes to sort of where it needs to go. Now we look at my big drive is driving this sort of, I think it's downstream, no, upstream. Wherever it's happening as preventative, that's what I want to see, upstream apparently. And if we look at Caroline's story, actually, this is very sadly has been a long time coming, and maybe there was things that could have been done a lot further upstream. So I suppose my follow-up question is, how does a neighbourhood model actually reorganise things that actually we don't have to hear Caroline's story because the problem was fixed before it's reached this point?
Peter, did you want to come in?
If it's okay to respond to that directly, I think the really interesting thing about Caroline's story, and I've looked at Alison close to the service on this, is that this was a model of what happened around social prescribing, proactive, versus models of social prescribing in the past, which have often, and social prescribing is just one bit of the workforce, but essentially it has been something goes wrong, someone goes to a professional and they get channeled into this kind of support. What's suggested here was different, was we didn't wait for the thing to go wrong. And the part of the Proactive Social Prescribing project, particularly here, it's around COPD, which has been what Alison's colleague Simon has been leading on, has been to find people on general practice registers where we know a certain amount of risk is there sitting on the computer system, the database essentially, but at the moment, to health, they're doing okay, and the measure of doing okay is they're not turning up at the moment, they haven't answered. But actually, the proactive approach says even at that stage, let's reach out to them, identifying them using that primary care data. And actually, part of the neighbourhood model is to say that data is incomplete because it only tells us what primary care knows. How do we join it up with the council's data and the voluntary sector's data to make sure it's a much more rich picture? Then we proactively go out to somebody like Caroline and say, we know that life is really tough when COPD is affecting your mobility and your connection to your community. Let's proactively come up with a personalised plan for you so that those risks are attenuated slightly, avoided, and therefore you're less likely to have those. And the idea is doing that on a whole city basis, where we have different needs in different places. You're going to get a very sort of one size fits all approach, but the ability to do that on a neighbourhood basis is much greater. It's much clearer where the need might be. And you might say, actually, in Westfield, COPD and diabetes are more likely to be issues, but over actually in Haxby and Wiggerton, it's these types of things. So it gives you the ability to be a lot more targeted. So I think that's where the model is going to change things into the future, if that helps.
Thank you, Peter. Sarah, did you want to?
Yeah, thank you, Chair. I think there's probably three things that I wanted just to comment on. The first is that this is the start of a conversation, and we'll need to continue, I think, discussion with Health and Wellbeing board members over the course of the next 6 months quite extensively to be able to really wrap our heads around this and scrutinise and offer challenge so that we can start to really build this up into a robust plan. So that's the first thing to say. The second thing I wanted to say was just to again also respond to Councillor Webb's question around where's the additionality of a neighbourhood model beyond what we're doing now. I think Peter started to touch on it. My perspective on this is that it is about creating a systematic approach to this so that you're not relying on somebody to spot someone who then is referred to the right service, which could take years and may not happen at all. So it's about having a systematic approach that creates an equality of access so that everybody in need, through really good data management, has the opportunity to be recognised by services, and doing that in a sort of approach to governance that you are seen by an organisation of a neighbourhood, as opposed to an NHS, a GP, a social care. So that's about the health and wellbeing systems locally starting to reorganise services in that neighbourhood way, and actually identify leaders within neighbourhoods. Now that's everything from community champions to ward councillors to general practice leaders and so forth, to work together. So they're not only identifying perhaps their top high priority numbers of people, that could be say 3,000 out of 50,000, but actually using that local knowledge then to design early help interventions that support people, and not just support people in the moment, but then provide onward care moving forward. Using the upstream, the access to the upstream support they have within their neighbourhood. So for me, that's the key difference. And, it shouldn't be about relying on referral. It should be that relational based practice that we can start to build with that organisation of neighbourhood. The third thing I just wanted to comment on, this isn't something I'm expecting partners to answer today, but I'm looking at our colleague from TRS and Weir Valley. I'm looking at our colleague from York Teaching Hospitals as well, to say, this is about larger providers as well, really getting their heads around neighbourhoods. And I think for York and Scarborough Trust, you might have 11 neighbourhoods to work with. And I think for Tuve, it's clearly going to be more than that. It could be 40 neighbourhoods. And clearly that's not going to be about reorganising so you have a dedicated team for each neighbourhood. That's not sustainable. But thinking about how you do relate to those neighbourhoods, and there are absolutely pragmatic ways of being able to achieve that, so that when you are a practitioner within a neighbourhood with someone who is clearly in need, that person has a named contact, know who they can pull in, and how to do that. So that's the work that I think the Health and Wellbeing Board needs to ensure is taking place over the next few weeks and months, so that when the plan comes, we can be assured that it's not just a plan and a vision, but actually that it can be implemented. Thank you.
Thank you, Sarah. Alison, did you want to?
Yeah, I just wanted to pick up Councillor Webb's comment about, well, social prescribing is there anyway, so why is it different? So it's there temporarily until the funding runs out in 12 months' time. And what we really want to see different in the neighbourhood model is we have social prescribing embedded and sustainable. So it's not just here today and gone tomorrow, negotiate the contract after 6 months. So that's what's different. We know social prescribing is integral to neighbourhoods. The ICB have told us that. It's something front and centre, because it's about putting care and support around individual people. And proactive social prescribing can be applied to anything, any condition. We just talked about it in Safeguarding Board about people who self-neglect. Social prescribing is an ideal way to pick up people who are falling out of the system, isolated at home. So I think for me, it's just about embedding it and having the data drive where we sort of focus the attention in the different neighbourhoods. So that's why it's there temporarily. Long-term sustainability would be good.
Thank you, Alison. Sarah, did you?
Thank you. I'll come back to Caroline, and I guess the questions from Councillor Webb might sort of inform some of this. I think this is a great story about how Caroline, it was spotted that Caroline had some problems and they were responded to, but Caroline's had a really bad year, and she's had a number of health conditions, and she's been housebound for a year, and been unable to leave her bedroom, go downstairs. That year has significantly impacted her health. So good that we've found Caroline and picked that up and responded to those challenges and helped her, by the sounds of it, to have a very different life. But even better, could we have avoided Caroline spending that year bedbound and experiencing all of those challenges? I think they're linking back to the population health data and considering the wider determinants of health. That's really hard to say. What we ought to be able to do is understand from within some of that data and some within some of those cohorts and within some of the what do people know about people in their patch. How might we have spotted that Caroline was going to end up potentially bedbound for a year if she's got COPD and osteoarthritis? My assumption is she's probably taken some medication. She probably does have regular contact with some health and care services. So, for me, it would be thinking about that, much further upstream and thinking about how we try and avoid some of these scenarios occurring in the first place. When I think about neighbourhoods, I think about a team around a person. So it's not necessarily about geography or places that people work from or spaces. It's I'm working with this person and their family. Who else is working with this person and their family? How do we make sure we join up a bit more? And I've seen lots of examples in my experience in social care and working across health and care systems where, for example, somebody might need some assistance with movement and they might need, an occupational therapist from the council who assesses for a fixed hoist, and an occupational therapist or therapist from the health service who assesses for the sling for that hoist or for the mattress that works with that sling. And I've seen those professionals literally pass each other going up the garden path when they go and see people. And there are often, we've got rules and ways of working that mean an occupational therapist who actually, those two people have the same qualification, they probably have the same or really similar training, can't necessarily access the same sorts of equipment and support. But if they talk to each other, if they know, or those teams know that person's got that need and they talk to each other, they might say, actually, perhaps just one of us could go. And that might save us a bit of time. It might mean we can get to somebody else faster, and it also might mean that the person who's got that need has far fewer people, tramping through down their garden path and through their front door. So I think about the team around the person, and for me, therefore, the primary, most important thing we need to talk about in neighbourhoods is how do people talk to each other and listen, and then what do you do about that? I think that's probably the main principle for me.
Thank you, Sarah. Sian, please.
I think in many ways, Sarah's just kind of made the point I was going to make in a different way. But I think that there's a real challenge for me around understanding neighbourhoods from our community's perspective. Because if you ask me where my neighbourhood is, it's not north, west, east or central. It's where I live. It's the nearest high street. It's the nearest schools. It's the library. It's the bits and pieces that you actually engage with. And that's a much smaller area. And I think when we're trying to talk about this with members of the public in York, and we're saying, we're talking about neighbourhood health and improving care near where you live, that has to be about how we work more effectively with individuals. And this isn't going to be for every single person in York. And we're going to be starting really small with really small groups of people to improve the care, the support, the opportunities for those individuals. And as we learn, we will roll out different things in different places to make sure more people have access to the right care. But I think there is something for me about the language in this, making sure we all agree that when we're saying things, we mean the same things by what we're saying. I think it's really interesting when you're working across health and care and the voluntary and community sector and the general public, that we all have our own ways of speaking about things, our own set of language, our own kind of beliefs and fundamental things that we do in the way that we work, and it's how we share those in a way that maximizes the opportunity to do the right thing when we're with people and to do the right thing for what they want to achieve in their life. So I think that there's an awful lot here that probably can't be unpacked and put back together in the Health and Wellbeing Board meeting, but I think there's an awful lot of conversations that need to be had with our population, with each other, with services, to make sure we all are clear about what we can do, what we can't do. And why should I care if I'm out there living in York at the moment about any of this stuff? How do we tell the so what of this story to people?
Thank you, Sian. And Naomi, would you like to come?
Yeah, thank you, Chair. I just wanted to come back on Sarah's point. I think it's absolutely valid. All organisations need to be engaged in this conversation, and as a trust, we are engaged in those conversations in multiple places. But I think, Peter, you said it, and another couple of people, York has a great foundation, I think, for building on the neighbourhood health work. We've had the mental health strategy for York as well, and we've got good examples and the beginnings of the community transformation and the impact that can have. So I think we've got a lot of that right. Sian's point about understanding our communities is really key. As an organisation, we've moved forward with our lived experience roles to try and get underneath that. I think it is really important that sometimes NHS and organisations will create this is a neighbourhood. It doesn't always match the communities that people will think about in their own minds, in their own places where they live. So I think we are engaged in all of those conversations, and this is something we want to build on. I think for me, I think it's excellent to see the presentation and everything that's outlined and the role of the Health and Wellbeing Board in there. But for me, I think the even better if, you know, we're moving to this collective responsibility, collective identification and the proactive approach, but it's how can we collectively understand the outcomes that are beyond, you know, the kind of the broader narrative. And I think that's where we'll get the impact and people will be able to connect with the why we do what we do and why it matters.
Thank you, Naomi. Lucy, did you want to come in?
Yeah, it was just to add to that as well, really, and give a bit of assurance from a York and Scarborough Hospital's perspective. We're also involved in those conversations, as Sarah knows, in a number of different forums through the working groups that were talked about and through the Health and Care Partnership as two examples. But yeah, absolutely. And we're having those conversations within our own organisation as well.
Thank you very much. And thank you, everyone. I think I keep being reminded to a comment you made, Sean, quite some time ago about, and it was about people who hadn't engaged and looking at it in a totally different way about, it's not about people who hadn't engaged, it's people we hadn't engaged yet. So, and looking at ways to engage those people, which we know people, we know our communities, we know the people who are there, we know the people who are going to tell us about issues in those communities. So I really, really do welcome this direction of travel and how we can be strategically involved with that coming forwards to absolutely get the best and play that really central role in shaping our neighbourhood communities. Thank you. Okay, so if we move on now to agenda item number 6, and that is Sarah with a verbal update from the York Health and Care Partnership, around 10 minutes, if that's okay. Thank you very much.
Thank you, Chair. I'll do my best. I've not been used to keeping to time over the last 8 months, so I'll do my very best. So first of all, just to start with an apology that there isn't a paper. I think this is probably the first time, notwithstanding I haven't been here for 8 months, but prior to that, the first time that we've not brought a formal board report. So I just wanted to sort of apologise for not providing you with something that you would have been able to see in advance. The reason for that was, well, possibly partly because I was, I think, first week back in the job when we had our York Health and Care Partnership meeting. But actually, I came back at a time as well where there was an awful lot of change going on with the Integrated Care Board, and also around the topic actually that we've just been speaking about in terms of the neighbourhood health policy. And I wanted to have some time really to just digest that, wait for more information to come through in terms of the ICB plans locally, but also the neighbourhood health work. And because there are some, I think it's a natural point for the York Health and Care Partnership to pause and to consider that national policy direction, and then therefore how do we position ourselves as a York Health and Care Partnership for the Health and Wellbeing Board, because we do report formally to the Health and Wellbeing Board. How do we position ourselves in the correct way forward? How do we position our sub-boards, which includes joint commissioning, the York Health and Care Collaborative, which is leading the neighbourhood health work we've just been talking about, and the mental health partnership. So how do we position all of that moving forward to ensure that York is in the best position possible to move forward in line with that policy direction? So what I wanted to talk through was then those two pieces of policy direction. I might as well start with neighbourhood health, given that we've just been really speaking about it, and I'll try not to repeat what we've already covered, but and I suppose I'll also lean into a bit of a health perspective deliberately, because just so that you understand kind of where the NHS is with it. But I think, as we've already said, you know, yes, the neighbourhood policy is core. Obviously, it's a local priority for the council, absolutely, and it is a core policy to the 10-year plan. NHS England, for the first time, has a GP as a medical director. So I think that's also helped in terms of position the neighbourhood health policy, right at the top in terms of the chief executive of the NHS at the moment. And indeed, that medical director has been to visit us 2 weeks ago across Humber and North Yorkshire, where we were informed that we were one of the most advanced systems. Humber and North Yorkshire has a number of really good examples of neighbourhood health in development, but actually York was singled out as having possibly been in the best position to actually scale neighbourhood working around a city, because when we talk about left shift, in terms of actually being able to start to move the workforce, start to work funding flows differently, start to deal with that on the day demand that is absolutely relentless in general practice and A&E systems and mental health systems. You need to do it at scale, otherwise you might be doing something fantastic in a neighbourhood of say 50,000, but you're not going to then see it in the impact that allows you then to take cost out of that downstream service. So that's where we need to kind of create that sustainable cycle, and that is then the key to year on year being able to continually invest greater proportions of investment within early help, prevention and so forth. So it's something that the NHS is really serious about, but as we know and as we've said, neighbourhood health is more holistic than the NHS. So the NHS position on neighbourhood is it's got a responsibility to get its own house in order to be a really effective partner to the wider agenda around neighbourhood health. But its role absolutely is about getting that on the day demand under control, when so people can get access within a couple of minutes to their general practice, can be seen quickly and efficiently within general practice and A&E services, so that we can create bandwidth for those services to engage more in prevention and early intervention. So I don't think the NHS makes too many apologies for focusing on that, because I think it feels like actually every other partner needs the NHS to be doing that, so that it can then play its part in a wider neighbourhood health model. Another element of the guidance that we've already talked about is that statutory duty that the health and wellbeing boards will be given to sign off the neighbourhood health plans. I just wanted to get on record a couple of bits of guidance that are coming. Peter mentioned that we were hoping that we might see something today. There's 4 pieces of guidance that we're expecting. Work around the model neighbourhood. So we will get a document that says what are the success factors, what's the key ingredients. We've got guidance coming to integrated care boards on new contract forms. So again, this isn't just about a vision or a plan, it is about contracting for new models, single neighbourhood provider contracts, multi-neighbourhood provider contracts. These are different forms to what we've had before, and it will incentivise providers in the NHS and potentially beyond to actually deliver this model, to make the money flow differently, to support the workforce to work differently, and so on. Peter's already mentioned the Better Care Fund, so I won't repeat that. The other element of guidance that we're receiving is about better use of physical assets. So we have, I think, just within York, within health, we probably, don't hold me to it, but 50 plus buildings that are owned or rented between general practice or between York Trust, between TUV, within the York city boundary, as well as, of course, lots of other civic and council assets. So if we're going to work in a way that is supporting people, and of course, a lot of that work doesn't need to be done in the same building, but actually it will really help if we have some ability to share premises rather than everything being done in splendid isolation in separate buildings. So there are some elements of what services make sense across multi-agencies to do together. So I think we need to, again, keep an eye out for that. And I think that question of what the involvement of this board is in terms of, being in receipt of all of that, so that we can then start to make sense of what that means for York in terms of our plan, are things to kind of keep an eye out for. The other thing that I'll just very quickly mention then is the Integrated Care Board policy direction. So and forgive me because I'm not sure how much information you've had on this previously, given that the announcement was made just as I went on maternity leave 8 months ago. But essentially the ICBs must make a 50% reduction to their running costs. That's the cost of running the organisation, so the staff costs, office costs, that kind of thing. Those changes have got to be implemented, or the running cost reductions have to be enacted by the 1st of April 2026. And the challenge lies in when you have a 50% reduction in those costs is, first of all, you've got to make sure that your statutory functions are delivered effectively. So the ICBs are responsible for continuing healthcare for children and adults, for safeguarding, for special educational needs and disabilities, infection prevention control in communities, and a whole range of other statutory services, which leaves very few resources for commissioning, which is also a key focus for the organisation. Commissioning will focus on, and this isn't too different from previous, but assessing population needs, developing the long-term population health strategy for the system, procurement, contracting, getting those contracts and incentives in place, and then evaluating impact of services. So in terms of how the Health and Wellbeing Board will be able to engage with the ICB as a strategic commissioner, it's going to be in that development of a long-term population health strategy and then the evaluation of the implementation. And for me, that comes back to not solely, but in large part to that neighbourhood health model. There's a really clear link there in terms of an opportunity to influence. And then I just wanted to make that point around the running cost reductions and reductions in commissioning. We're expecting there to be approximately 150 redundancies that will be implemented over the next few months. The outcome of the ICB's consultation is expected on the 10th of February. So that's when we can start to see the implementation. That will take a number of months to work through. So I think we'll be at the summer when we start to see the impact within place of those reductions. And I think it's fair to say that strong partnership working remains vital. And as we've just been talking about in terms of neighbourhood health, but there will no longer be teams dedicated to place funded by the Integrated Care Board as we have now. And I think the model will very much move from ICB being a leader of place by virtue of the fact that it has funded quite substantial teams to being a partner of place. So again, as the director of the York Health and Care Partnership, I am one of my sort of key priorities now is to work through with those leaders so that we are on the front foot over the next few months to really understand then how we move forward as a York Health and Care Partnership Board. The Integrated Care Board has confirmed that the Joint Committee will continue to operate. It will continue to report to the ICB. It will continue to report to the Health and Wellbeing Board and remain a formal committee of both, which is really helpful, I think, to have that clarity at this point. It's about then how do we evolve that joint committee so that it can be, again, as effective as it can be on behalf of those two bodies, and to deliver then the work that's required in York. So we will know more about that, and certainly the next meeting, the next formal meeting of the Health and Wellbeing Board, I will be providing a formal report that sets out the operating model for York Health and Care Partnership moving forward, as well as the minutes from the previous meeting and a report that covers the points that would have been there had I produced that formal report today, Chair. Thank you.
Thank you, Sarah. Thank you very much. Can I just ask a quick question? Do you have, the 4 pieces of guidance that you said were coming, do we have any idea of timescale on them, or is that not really?
So the main bit of guidance for Health and Wellbeing Boards in the production of the Neighbourhood Health Plan, we were expecting, I was expecting to have had it today, which is one of the reasons I delayed the report. It's now expected mid-February, and the other pieces of guidance are all expected before the end of April.
Okay, thank you. And just an acknowledgement really that it is a really tricky time for staff, and the reports I'm getting is that staff are continuing to power through, work hard, despite it being really, really hard times at the moment. So thank you. Did anyone have anything they'd like to comment on or ask Sarah? No? Okay, thank you very much. Okay, so if we move on to agenda item number 7, which is water fluoridation, and we have around 15 minutes for this item. So Peter, if you would like to present, that would be great. Thank you.
Thanks very much, Chair. Well, this is one of those reports that there's a bit of an ask at the end, so just bear that in mind, everyone, just in terms of approval for this. The report hopefully sets it out. There's a lot of detail in the report. There's a lot of science within this report that I'm very happy to take any questions on, or to take questions outside, bearing in mind the time limitations we have on this. But I just almost want to summarise the kind of the why and the what and the how of this report. The why is because this is the leading cause of children between 6 and 9 going into hospital, 22,000 children getting admitted to hospital every year in the UK because of essentially teeth decay, where they're having to generally have general anaesthetic and that teeth pulled out. Very distressing, very bad for outcomes. Beyond that, obviously, lots of other people go into hospital because of poor dental health. Our oral health isn't brilliant as a nation, and it causes all types of health issues and distress, as well as costing us a huge amount of money in what is essentially quite a preventable way. So oral health is a big issue. It's an issue that is getting worse over the decades, and we need to do something about. I think just in terms of the what then, what we're building on in this paper, what is being explained in this paper, is a topic that has been debated and been talked about, and has also been implemented and sometimes de-implemented for probably 80 or 90 years. So this is not a new debate. I do note we obviously had some public comments from a speaker raising some issues which have been extensively debated in numerous different places. And I might tackle one or two of them now, but I'm really happy to speak to that individual and answer the questions in detail through correspondence. What I would say is that at point 15 in the paper, what we're suggesting and talking about here, the addition of fluoride to our water system, is supported by all 4 of the chief medical officers in the United Kingdom, the chief dental officer of the United Kingdom, the British Dental Association, the Royal College of Paediatrics and Child Health, and the British Society of Paediatric Dentistry. So there's significant weight of professional opinion behind this. The weight in terms of effectiveness, the science behind what having fluoride in your water does in terms of reduction in dental caries and admissions to hospital, but also the science behind the concerns that have been raised about effectiveness and safety is laid out in part in the paper, but I didn't want to overwhelm people with too many words. So there is a lot that lies behind this. One of the things that adding fluoride to the water does that is not the case with generalized things like toothbrushing, fluoride varnish, which are talked about in the paper, and we do invest resource and money in York to do these things, is the universality of it. This gets to everyone, and in particular, and the diagram that you'll see at point 19, has a remarkable effect on narrowing the gap. Generally, it's our poor and deprived children who end up in hospital with this issue, but in areas which have fluoride in the water, that is much less the case. One of the things to feed into the arguments about, or rather the reasons why this is an idea we can push forward on, is that actually we already have 6 million people in the United Kingdom with fluoride in their water. That's either through natural fluoridation, or in some areas it's through the addition of fluoride to water through schemes that have been there since the 1960s in places like the West Midlands. And this has been tested, therefore. To answer the point that was raised around areas that have stopped adding fluoride to the water, actually the paper does speak to a number of studies which suggest that that has had a really bad effect on children's dental health. And so actually those offer another, for me, piece of quite strong evidence for why this is a good idea. So I'm still on, I guess, the what here, and just to tackle a couple of other bits. I know sort of public speakers raised issues around, I guess, the consent aspect of this. The MHRA, who are the body who determine what a medicine is, fluoride is not a medicine for the MHRA. Fluoride is a part of our water system in the same way that we are we are having intervention on the water that we have in, because obviously we have to treat it to make it safe, to remove impurities from it, whether they are substances or bacteria or viruses or that sort of thing. So it's part of that water treatment process. It's not adding medicine. Fluoride doesn't count as a medicine internationally. It's also something that 6 million people are already receiving without having given their consent. So for me, the issue of consent here is actually democratic consent. This isn't individual consent. Much medicine is based on, as a patient, do I consent to this as an individual? But there are plenty of things in terms of our air and the air that we breathe, in terms of the water, in terms of the content of our food, that we don't ask individuals for every purchase or every glass of water that they have. Do you consent to drinking this? We take a democratic mandate, and that very much, I think, is where the country is moving. That's why at the moment, the pilot area for this, in terms of the new introduction of fluoridation in the Northeast, has seen extensive public consultation, a very large consultation with lots of response. It's seen lots of professionals inputting into that evidence, and the Northeast have probably been on that journey through a number of different studies that they've done in terms of feasibility and in terms of the public opinion on it for 10 years now. The Northeast are pushing ahead. The government has given them the go-ahead to roll it out. And the reason, to move on finally to the how, that you're getting this paper now, is that as directors of public health in Yorkshire and Humber, we would like Yorkshire and Humber to be one of the next regions to go with this. There are lots of other regions that would like to be next on this. We know that proactively, actually, we are one of the better placed regions for certain issues of geography, and we know there is broad support. But what really helps in getting that broad support is public bodies like a Health and Wellbeing Board saying, yes, we're happy to support in principle that type of addition. It's not something that we can make a decision on, hence there isn't a public consultation because we're not the decision makers on this. If Yorkshire and Humber, through Yorkshire Water, were going to be introducing this, there would be a full public consultation to answer again that question. So what we're being asked to do here today is support in principle the addition of fluoride to the water for York. But in order to put feet to that, what I'd like to propose, Chair, is that also we ask the leader of the council, Claire Douglas, and we have sort of had a discussion about this, to write to the Secretary of State, just reinforcing that this is the conversation our local set of clinicians, elected members, senior officers, those in the voluntary and community sector have assented to putting their names to a bit of a letter and statement. We know that that is something the Secretary of State is proactively looking for from leaders, and there have been discussions, hence the timeliness of this paper coming to the board. So I'll stop there, Chair. Happy to answer questions, and would love to have a bit of an answer about us supporting that in principle by the end of the item.
Thank you, Peter. And as Peter says, it's not a decision, it's a steer. So really, really interested to hear on anyone's opinions around this. Alison, please.
Is there any evidence of negative side effects to having fluoride in the diet?
The key negative side effect is fluorosis of the teeth, slight mottled effect, which in a small portion of people who get it, they self-report that they'd rather they didn't have that mottled effect in their teeth. It has absolutely no impact to oral health having fluorosis, and the benefit and risk there is essentially what we have to weigh up. You know, it's the level of distress, decay, admission to hospital, time off school, lost economic productivity against essentially what is a cosmetic impact there, which is fluorosis. That is the harm that I would say has got strong evidence. There have been plenty of things that people have said may be harms for fluoride stretching back over 100 years, and a very, very large body of scientific evidence looking at whether those are true harms or actually they're just correlation without any evidence of causation. The two studies that we note in the paper are lotus and catfish, very, very large randomized control trials. There are also, as I say, studies where you take it away and you see the detriment to oral health. I'm almost loath to sort of almost go through the number of things that have been thrown at fluoridation, as in these are the 19 different harms, because everything has been blamed on fluoridation. And there is actually something a little bit about repeating myths, and people remember the myth rather than remembering the truth. I guess my assurance is, along with the professionals that I named to are significantly higher up the public health food chain than me, is that the benefits are very high, the harms are unproven, the safety and effectiveness of this, similar to an intervention like a vaccine, is never going to be to the absolute 100%, but all things like this are a way up of harms and benefits. The benefits significantly outweigh any harms.
Thank you, Peter. Naomi, did you answer?
Expertise. Forgot about the mic. Thank you. Okay, I'll start again. So I just wanted to make a comment. This isn't my area of expertise. However, I think the evidence base is very clearly laid out in the document. And I think it links to our previous conversation that when we're making decisions or recommendations, we should be informed by an evidence base, particularly around health. And I think it does very strongly link to the sickness to prevention, left shift that we are guided in the strategy, our health strategy, and the impact on long-term health. I think is a compelling case.
Thank you, Naomi. Councillor Runciman.
Thank you, Chair. This is a subject which I feel very strongly about. I've been campaigning for fluoride in the water for, I don't know, 50 years, perhaps more. I'm very proud to say I have a very grown-up daughter without any dental caries, because she had fluoride treatment when she was little. I circulated our group. I got one query, and I think I've settled the query. Other than that, the report I sent round was accepted, and I hope that the group now will accept that this will happen, and it will do the world of good for a lot of very young children, let alone when they grow up.
Thank you, Councillor Runciman. Councillor Webb.
Yeah, thank you, Chair. I think, firstly, I think that this paper is actually quite narrow in talking about the benefits long term. I mean, there's again, not my area of expertise, apart from having terrible teeth myself, if I'm honest, but the difficulty of performing many tasks when you're suffering from tooth pain is particularly challenging. From personal experience in my professional life, tried teaching children physics when they've got dental problems. They've got more things on their mind. But I think there's wider benefits to improving dental hygiene, dental health here, that stretch further into people's adult lives that we really shouldn't miss. And the last thing I'll say is I think all this myth, it comes around this idea of putting chemicals in water. And I have to remind people that water is a chemical. H2O, it's got hydrogen and oxygen in it, to be really clear. But because we're talking about a chemical that people know less about and it's not as common, that there's suddenly, it's really easy to jump on that bandwagon, which is a big shame. So yeah, I think this is a really positive move. I do think we should support it, and I hope that we can push this forward. Thank you.
Thank you. Sian, would you like to?
Yeah, I just wanted to say, I think we haven't seen the statistics on how many dental caries have been removed from children in hospital for a while, because I think they stopped collecting it for a little while around. But we used to have quite high levels, surprisingly high levels for a city like York. And yeah, absolutely. If you are under 5 and you've already had teeth removed, it feels to me like we're not getting something right. And whilst I would love to be able to fix dentistry overnight, we're not there. So I'd find it hard not to support something like this, because I think the evidence base is there. There have been study after study after study. that there are lots and lots of, like Peter said, unfounded myths about what fluoride will do to people, but we haven't got the evidence that says that's true. So yeah, I would be quite happy to support this.
Thank you, Sian. Sarah, did you want to add something?
Yeah, so just to offer a ICB and NHS commissioning perspective, because we commission dental services as well. But I think I just want to refer to the ICB's purpose, really. What's it there to do, and in kind of in terms of what I say next, which is this is in terms of interventions, this is possibly the single biggest thing that we could do in terms of cost effectiveness for the NHS and other services, in terms of all of those interventions, outcomes for children, for adults, in terms of the pain that they're living with, inequalities in terms of the gaps between the haves and the have-nots, and the impact that that then has on the wider determinants of health throughout their lives, in terms of, as we've said, education, work, stigma, trauma, so just to really offer the support of the Integrated Care Board in moving forward with this. Thank you.
Thank you. So I think I'm hearing quite wide support, and I also think that if we are serious about reducing health inequalities, this is something that really gets to the heart of tackling health inequalities in the most vulnerable children, not just the children though. And I think I've spoke before about how the lifelong stigma of teeth is such a big thing for people's confidence, and people not wanting to go to job interviews or see other people because of their teeth, because it is such a big stigma around confidence. So I think the support that you're hearing across the board is quite broad. Peter, thank you.
And Chair, just to say that second recommendation about the letter, I will try and put some wording in, and if Ben, if we could just, and Tracy, make sure that's recorded for the minutes. Thank you very much.
Okay. Thank you very much, everyone. So now we are going to move on to agenda item number 8, a compassionate approach to healthy weight. So we have, Peter is going to present this, and we also have Phil Truby here to present the report. We've got around 15 minutes. Thank you. Oh, we're going straight to you, Phil, apparently. Thank you very much.
Great, thank you very much. Hello, everybody. I'm Phil Truby. I'm Head of Public Health at City of York Council. So I'm here today to talk about the paper, A Compassionate Approach to Healthy Weight in York. So I just want to outline initially why I feel a new approach to healthy weight is needed. Previous efforts have been fragmented, and we've got separate services working disparately to support individuals around their weight status. There's an increasing body of evidence around weight management services in their traditional format just don't have long-term impact on weight status for both children and for adults. And I think there's a increasing recognition that obesity is a chronic relapsing condition. It's not something that happens in isolation, and it's really strongly linked to trauma, poverty, mental health inequalities. There's a real growing body of evidence for that. And it's a result of the wider societal and environmental factors, so food systems, transport, planning. So in a nutshell, what do we mean by a compassionate approach? I think it's something that we've sort of touted, but what does that actually mean? And I think it's a shift away from a weight-centric focus, a focus on actually how much does somebody weigh, what is somebody's BMI, and a shift towards a framework that focuses on an approach to a trauma-informed social justice type of model that looks to challenge weight stigma, that prioritises health gains, that we're talking about respecting diversity in body shape and body size, and then also supporting enjoyable engagement in physical activity for everybody. We're looking at those societal and social barriers to engaging in physical activity and to a healthy diet and nutrition, but also looking at the underlying causes that affect someone's weight status. So actually, as I spoke about, a trauma-informed practice. Obesity isn't happening in isolation. It's complex factors, and it's a whole system-wide approach that we need to address here. Not weight doesn't happen in silo and in isolation. And I think we need to be mindful of the unintended harms of traditional weight management services that have gone before, and the sort of the contributing factors that they have to eating disorders and the risks that are associated with those. In terms of the services that we have around these, we are really taking a preventative approach to this, and I think it's really important to describe in a few steps just some of the services that we have around providing support to healthy weight within the city. From a local authority sort of public health perspective, we really want to develop a really cohesive pathway that starts at preconception and travels all the way through the life course. That is explained on page 50 of the report. There's sort of a flow diagram there. So I'm not going to go through each element in turn, but I just want to say that there is something at each stage of life course. And we have previously identified that there was a bit of a gap in provision, particularly for school age children. So in response to that, we've developed a new Healthy Families programme, which is about to launch. It launches just after February half term. And that is really it's based on the principles of our adults health trainer service, but designed specifically to support families and family-based intervention. So we are just in the final stages of getting ready to launch that service offer. It's initially going to focus on the outcome from the National Child Measurement Programme, so the letters that are and the weighing and measuring that happens at reception and year 6. At the moment, the process for that is that a letter is sent out with a result, and there's no offer of support there. It's a direction to national resources. We know that those letters can be quite stigmatising, can be quite come out of the blue for families. So that this offer is really designed with families in mind. There'll be a proactive approach before the letter lands, so people are sort of geared up to the fact that they're going to be receiving this information, and then it really is a family-centric approach to realistic changes that a family can make in terms of, this isn't a weight management program, this isn't a diet program, it's what can we do to support you and your family as you are to make lifelong behavioural changes. Obviously, coming to talk about healthy weight, you can't not talk about these days around weight loss medications. I don't particularly want to focus in on those too much at this stage, but I did want to acknowledge them. I think for me, as you would expect, coming from a public health approach, it's very about the preventative approach and what we can do to support individuals. However, there is absolutely a role and function for weight loss medication. They are effective. They do result in significant weight loss for individuals who take them, but they don't come without their risks. They are expensive to deliver, about to the tune of just over £120 per patient per month would be the cost to the NHS. If we wanted to treat everyone who was living with obesity in York, we'd be looking at a cost of around £62 million. So it's an expensive intervention. And there is the question of what happens longer term if there's not wraparound support around those. It's great to kickstart weight loss, but that needs to be supported with looking at all of those environmental and societal factors around that individual or around that family. So yes, that's all I'm going to say on weight loss medication for now. In terms of wider than specific sort of health focused services, as I said previously, obesity is a system level approach and a system level actions that need to be taken. So some of the actions that we're taking as a local authority are around looking at our approach to advertising and sponsorship around products containing foods that are high in fat, salt and sugar, and looking at restrictions on the advertising of those, looking at how we can expand and increase access to healthy and affordable food. And we are working with our planning colleagues to look at how we can incorporate health into our supplementary planning document, because I think actually you've got to embed these principles really early on and make them as accessible and as available as possible right from the outset. So the next steps and recommendations for the board is, I guess, for me to emphasise that this is a whole system. This requires all partners around this table. This can't be led solely by health. It can't be led solely by public health. It needs all organisations to really chip into this. And so my ask is that we approve and promote the compassionate approach to weight loss across all organisations, and where possible, look to embed trauma-informed practice, weight stigma reduction, a focus on holistic health, rather than just weight outcomes, and have a real consideration of those commercial influences on food and activity choices. Thank you.
Thank you. Thank you very much, Phil. So as Phil said, we're being asked as the board to endorse the ethos behind the proposed compassionate approach to healthy weight. And if anyone would like to discuss or consider the implications of this approach for their organisation, that would be really great. Thank you. Naomi?
Yeah, thank you. I just want to comment that I absolutely welcome the change in approach. We know that people, particularly with a severe mental illness, severe and enduring mental illness, there's a direct link with obesity, and any measure that is less stigmatising and people can engage with, I think, is an absolute welcome. And other mental health conditions as well have that interrelational link with their health and weight as well. As an organisation, we were involved in some research in recent years and took a particular approach for mental health. So I think as a partner, we would absolutely be supportive of this approach, and we'll already have some foundational work in place.
Thank you. Phil, can I just ask a question, please? And it may have been in the report and I've missed it. So if we're looking at this compassionate approach to healthy weight, and we were talking about how some of the past approaches hadn't been great for long-lasting outcomes for people, is there evidence that if we focus more on health gains for people and becoming healthy rather than solely a weight loss program, that has better long-term outcomes for people?
Yes, absolutely. I think is the short answer to that. I think it's really when interventions focus solely on weight, it misses so much else in terms of someone's holistic view of health, and someone can be of healthy weight and chronically unhealthy, and the same can happen the other way. So I think for me, actually embedding these real basic principles around physical activity, nutrition are really key, and being able to communicate those benefits to families, to individuals, to groups, to organisations, it will result in better outcomes for all across the city. And I'm not naive to say that obviously there's different sections of our communities will experience greater challenges in achieving those than others. So any of the services listed there would need to be proportionate and directed to where the need is greatest.
Thank you very much. Councillor Webb, did you want to come in?
Yeah, thank you. So two questions that are in very, very different. So my first question, I suppose, is from a council point of view, is how is public health engaging with other parts of the council, for example? So, if we look at transport, getting people active, whether that's walking, cycling, wheeling, whatever that is, could have a huge positive impact on the health and well-being. But that obviously isn't something that you directly influence, but then it's how do you have that influence on other sections of the council? And there'll be other areas as well that link into this directly. My other question, because I'm living and breathing it at the minute, is weaning, and I'm a relatively new dad. My little lad's a 1 year old now, so we're in that process of changing, and the diet changes rapidly over a short period of time. There doesn't seem to be a lot out there for that bit. That there's your NCT groups prior to birth, like how do you change a nappy and all that sort of jazz, and that's great fun. But then actually that next bit, it personally sort of feels like there's a little bit of a gap there, really, in sort of supporting families to do that bit properly. And I feel like if that was addressed, that could then, if you look at your flow charts, it fits in almost between sort of the breastfeeding and the Healthy Start vouchers, doesn't it, really? So I'm just sort of thinking, if anyone's got any ideas. So there you go. Not on specifically me. You can tell me afterwards if you do, but
I'm happy to come back in on that. I think So on the active travel thing, we're absolutely working closely with colleagues in transport and in active travel specifically. We, as you know, last year the city hosted the National Active Travel Conference, and I was there and working really closely with colleagues in that team to look at how do we embed active travel. You know, we have one of my colleagues works on the Active Schools programme, and you know, links in really closely around looking at how do we promote walking and cycling into school, how do we embed that across school programs as part of the Healthy Families and the Health Trainer programs that we deliver already. They're some of the really easy interventions that we discuss with people around easy ways to increase physical activity. So that is definitely front and centre in our thinking. I think as well, we are working closely with colleagues across children's in terms of the Raise York partnership and the Best Start in Life interventions. The healthy weight in under fives is one of the key priorities for the Raise York partnership. So I'm working closely with colleagues across the Raise York partnership around how we do that. On your second point about weaning, it's a really good observation. I will take that under consideration. Absolutely. We do have, as part of that pathway, one of the offers is the Henry programme, which is health, exercise, nutrition in the really young. And one of the specific topics within that is around weaning. So there is an offer there. It's limited and could look to be expanded more. So yeah, I will absolutely take that. Thank you.
Thank you. Sian?
Yeah, I was just going to say I fully support this as well. I think it's a really important move. I think I remember reading a study about the impact of working with a group of people who were living with obesity, and there was no support put in place. There was no attempt to understand their reasons for being overweight. And so they were just put on a strict diet, and the diet had the effect of helping them lose weight, but actually the impact on their mental well-being was disastrous because there was no attempt to really understand that complex relationship with food that those individuals had developed. The focus was all on getting them to be thinner rather than actually helping them be healthy, well-adjusted adults. So I think this is absolutely the right thing to do. I think it's really interesting to think about what we could collectively do to help progress this, to make sure the messages we give to our population are right. I also want to pick up on the point about weight loss drugs and injections. And I think there is something quite alarming for me about normalising that in an environment where we know many young people have got quite a lot to say about body image and the sort of the impact on their mental well-being of expectations to be a certain way. So I think this is much more helpful, much more supportive of understanding where people are and what we can do to help them be there where they want to be. And yeah, it's great.
Thank you very much. Thank you. Councillor Colwick.
Thank you, Chair. I'd be really interested to hear a little more, if you would, about the supplementary planning documents you referred to and the sort of content that you might expect to find there in terms of planning.
I'll pick that one up. Could be either of us because I know we've both been involved, Phil, haven't we, in this? And so the local plan has a specific policy in it, HW7, which is about the need for developers of major strategic sites to offer a health impact assessment. Health impact assessments are well laid out by other areas. We are on the cusp of getting to the point of publishing what our frameworks will look like, so they're not there yet. But broadly, assessing the impact of a new development on things like this and the guidance that we'll lay out, which will be either in a supplementary plan document or just guidance. That guidance will look at things like the way the layout of a particular development might enable people to get from A to B without using a motor vehicle, for instance. It would look specifically at aspects of the planning policy that are now in the National Planning Policy Framework around hot food takeaways and the extent to which you can put additional planning objectives around where hot food takeaways are cited. The typical ones, but local areas often define their own, would be within a certain radius of schools and clustering of hot food takeaways, so more than a certain number per head of population, or in areas where there is higher levels of obesity, and that's still to be defined. So that's one way in which the process could be part of it. I think there is also just that general ability for people wider than the development, but thinking strategically across the whole city about how we enable people to get from A to B, again, without using a car, and then how we enable them to access the things which we know increase physical activity, like sports provision and green space. So there's going to be quite a lot in there, and there already is a process around developer contributions for those things, but how we make sure that future developments have the right green space in the right places, and that there is contribution to our sports and active leisure provision in the city, so that if we add 30,000 more people, we also add the equivalent amount of ability to be able to access those different bits of provision.
Thank you, Peter.
Thank you.
Okay, thank you very much. So it sounds like the board is widely supportive of this. I think it's really, really timely, and it seems that we should be taking a holistic trauma-informed approach with this, as we are with other things, and the recognising that it is not something that exists in isolation. Thank you very much. Okay, so if we move on to agenda item number 9, we have the City of York Safeguarding Adults update, and we have Jane Timpson and Michael Melvin. Thank you so much for waiting patiently. So we have 15 minutes to consider and note the contents of this report. Thank you.
Thank you, Chair. I really appreciate the time as the independent chair of the Safeguarding Adult Board in the City of York to bring the annual report. I mean, the purpose today isn't for decision making, but just to highlight the work that we've been undertaking in 24-25 and the contents of our strategy for 25-28. Now, there are at least 6 people sitting around this table that are part of the Safeguarding Adult Board. So it is certainly of interest to the Health and Wellbeing Board, and I'll highlight that as we go through. Hopefully you've had a chance to peruse the report that was part of your paper pack. In fact, I have got a presentation, but I don't know whether that's... Anyway, hopefully we'll get that, otherwise you'll just have to listen to me talk. But this is my first full year as chair of the board, having started in July 24. And also another pivotal thing that happened in May that year was the employment of a board manager. And I think that's really helped the board progress on some of the priorities and really focus our energies on what difference can we actually make to those who are at risk of abuse and neglect within the City of York. And I'm bringing the report here because safeguarding isn't done by one organisation in isolation, but it has to be a system response. That's the responsibility of all organisations around this table. And really, I would say members of the Health and Wellbeing Board need an enhanced understanding of safeguarding in order to support that work. So local authorities do have duties to safeguard adults who have care and support needs and who are at risk or are experiencing abuse and neglect, and they're unable to protect themselves. In York, the Chief Operating Officer has delegated the responsibilities to the Director of Social Services, as well as the lead member for Adult Services, who are the key points of professional and political accountability. And agencies and providers have responsibilities to promote wellbeing and provide advice regardless of whether a statutory adult safeguarding duty applies or whether the local authority has identified an action for itself following a safeguarding inquiry. So the Care Act, where that's embedded, is now 10 years old and has been guiding how we deal with adult safeguarding and what we need to be considering. As well as the Safeguarding Adult Board, there is an absolute link to the Safer Partnership in York, to the Children's Safeguarding Partnership, as well as the Domestic Abuse Partnership Board and others, where
we try and work collaboratively, because at the end of the day, and I think there's been a real theme this evening about the neighbourhood approach, and really what I'm going to be talking about is that, but with the focus on safeguarding going forward. So one of the things that we did in 24 to 25 was to implement a new governance structure to more robustly support the delivery of our strategic plan. So streamlined in some areas, built other subgroups to really help the areas that we felt were, well, needed more development that way. It's actually quite helpful not having a presentation because I can click through pages that are not quite so useful for you. I think it's important for this board to recognise that the board does have 3 core duties in accordance with the Care Act. One is about developing and publishing a strategic plan. We have put that in the papers for you for the 25-28 strategy. Publish the annual report, and part of that is to make sure people are cited on it, and also commission safeguarding adult reviews for any cases that do meet the safeguarding criteria. You heard about Caroline earlier. Within our annual report, we talk about Tessa. At the end of the day, it's a similar thing. It's about someone with multifaceted need and how a partnership needs to come together to provide the right response to that individual in a timely way. And we, as a board, we need to be focusing on preventative measures, not just the reaction to when abuse and neglect has happened. Capturing the voice of and the lived experience of adults is extremely important to us as a board, and we've tried our best to strengthen that this year. So we do have a focus on that. It isn't just about data or responses. We are really doing our best to make sure that the voice of those adults is influencing what we do as a partnership. Some of the stuff that we've done in 24-25 is to finish off the strategy that ran from 22-25. It's really been about embedding some guidance for all professionals and staff working in the realm of safeguarding. We've obviously strengthened our partnership working. We strengthened the membership around the board to make sure that there was more of an emphasis on those organisations that do represent individuals and people in the City of York. We've published self-neglect practice guidance because we already can tell from the learning that we're getting out of safeguarding adult reviews that that is an area that we have to improve on as a system. One of the other things that we need to improve locally is all people working on the frontline service to have better professional curiosity. So we've published guidance to support staff working and responding to situations. And also an escalation policy because, protocol, an escalation protocol. One of the things that we've learned from SARS is I think it's easy to make a referral, not so easy to be tenacious and follow it up and making sure that the right response is happening. So the escalation protocol is allowing partners to find a way of making sure that their concerns are listened to. We've had a very successful safeguarding week by trying to raise awareness amongst providers, members of the public, as well as organisations to enhance our safeguarding knowledge. And also really the focus on this 24-25 has been dealing with a backlog of safeguarding adult referrals. And I think during this year, we processed at least 7 safeguarding adult reviews, which is an extensive number, but that has provided some solid learning about where we need to improve locally. So, there are some statistics, I'm not sharing those. What I will say is that concerns increase year on by at least 10%. No change this year, and I don't suspect there won't be any change going forward. That doesn't mean more people are being abused within the City of York. It's an indication that there is greater awareness about how to raise a concern and people understanding their roles and responsibilities in relation to that. So the key takeaway from finishing the strategy for 22-25 is that I think we can now say that we have got a very proactive community and that there is benefit from working together across York, and we've also this past year really strengthened our relationship with North Yorkshire, so that we're trying to do things collaboratively with our North Yorkshire colleagues, which is of benefit. I'm getting nods here. Benefits to our partners who have a shared footprint, because we're trying to make sure they're not having to do things multiple times, where we can actually share the findings of, for example, a self-assessment, where we can do now in a regional basis. So there's only one submission rather than 3 or 4 or whatever, however many awful ones you were having to do previously. So going forward, like I say, the learning from SARS has been absolutely that we want to improve responses to exploitation, and also to individuals who are experiencing self-neglect. We also know, like I said already, about the professional curiosity. It's about supporting professionals who are working in safeguarding to have the right response, stick with it, and then in order to support the individual collectively across our partnerships. I think we've been able to, one thing that it does show in the annual report is that we've been able to demonstrate the impact of learning from safeguarding adult reviews by asking organisations to list the impact a SAR has had on their own individual practice. You'll see that on page 59 to 62 in the report. If anyone's interested, we absolutely have a more detailed report demonstrating the impact of those safeguarding adult reviews, and we can share that with you as part of your papers going forward. So just let me know if that would be of interest. So the strategy for 2025 to 28, which is also in your packs, has been developed by examining evidence from the board's work over the last couple of years, listening to partners' feedback, certainly at the challenge panel that we held in January 25, and also from trends and themes emerging from data, and also from the recommendations from the safeguarding adult reviews that we've held over the last couple of years. So for the strategy, there's still going to be a focus on prevention, awareness and engagement. That never goes away. We need to make sure that people within the City of York have the confidence to know how to raise concerns. We are going to continue to learn, reflect and improve practice. But really what the main focus, and I think those two will fall out, is from strengthening multi-agency safeguarding responses to adults at risk of exploitation, rough sleeping and homelessness, and like we said, self-neglect and hoarding. All those 3 areas are absolutely supported by the conversations you've already had about that neighbourhood approach. It's the only way to do it. It's about us sharing information with each other. It's about finding ways of making sure information is shared, and that way partners can be responsive. And an example of that, which we've heard today, was, for example, in relation to self-neglect. If someone is going into hospital, it's about making sure the hospital is aware that the home is not habitable and that they should not be discharged to it, and then that wrap around by organisations to find a solution to that issue. Today we did sign off a thematic review that looked at no less than 7 deaths of individuals who were self-neglecting and hoarding. We can't say it's a one-off. We know there is a systemic issue that we have to address head on. So in relation to the work that we're doing, if I start off with exploitation, that we have got a task and finish group looking at that, that's led by North Yorkshire Police. It's working with the Children's Safeguarding Partnership, and obviously Children's Services and Adult Services in supporting the response to adults who are exploited. Now, particularly within that transitional age group of 16 to 18, making sure that there's a continuous approach and that there isn't a kind of a cliff for young people to fall off. One of the things that we can do about that is also improve the ability for all organisations to report on people who may be in a position of trust who is causing a concern. Now, that's not just in the work about poor practice, it's about what might be happening in their personal life and how they're treating others, and whether that
raises concerns about their ability to care for someone with care and support needs. We've also worked hard, and Michael's been pivotal to this, to the development of a dashboard. It's been hard. It's still a work in progress, but we can really see the dividends of that we can now track concerns through the data, and we were able to raise points today at our safeguarding board about what the data is actually telling us and where we might want to be getting some more assurance about how the system is working. In relation to rough sleeping and homelessness, I'm looking at Pauline here because while the City of York have a robust rough sleeping and homelessness board, the safeguarding board are obviously very interested in making sure those responses to those with care and support needs are pivotal to that as well. So Pauline has been a trooper and is leading on that for us from a task and finish group perspective. And we've had specialists coming in to help formalise our thinking about what we need to do locally. But it's not different from what you've heard in relation to the neighbourhood model. It's the same response. And then finally, for self-neglect and hoarding, we are in the process of developing a multi-agency risk management protocol, which will then give partners an ability to hold those discussions and a framework in order to respond to concerns where there's real high risk of an individual who is struggling to engage with the offers that we're making. So, and the learning from our SAR that we signed off today was that there's clearly a need for a system change, and you've already talked here about team around the person. Exactly the same in relation to self-neglect. And we also need to ensure that individuals are being referred early so that we can do preventative work and then stick like glue to that person and move away from an attitude where we can say they don't want to engage with us. We have to be more tenacious and find a different way of approaching that person so that they feel safe and confident in order to allow partners to support them with the issues that they're facing. If I had a presentation on the back, it would give you contacts about how you can make a safeguarding concern, raise a safeguarding concern, and also links to the multi-agency policy and procedures. But if there's any questions, I'd be more than happy to take them.
Thank you very much, Jane. Is anybody? Sarah?
It's not a question, it's a comment. I'll keep it as brief as I can, Chair. So we know that there's much more that we need to do in York to continue to strengthen our arrangements for how we work together to help adults in York to live independently, safely and well. We know that from our own self-assessments and learning from listening to and hearing from people and also from our recent CQC assessment. But I just wanted to reflect really that in the last 12 to 18 months, there has already been a really significant amount of improvement work. And just to thank Jane really for her leadership as our independent chair. So she's been energetic and motivated and committed. And I think it's fair to say when you came in, you know, we did see that there was an awful lot to do, but you've absolutely led a significant amount of work and change, supported by Catherine Laura, our board manager, who's not here tonight. And I feel really confident that you're going to continue to support us to lead those improvements as we go forward. So thank you.
Yeah, I'd like to echo that absolute thanks as well, Jane. It's been really useful. It's been really useful to look across the whole council as well, because I think we've even looked as far as councillors doing the safeguarding stuff and bringing it across everyone and really emphasising that it is everyone's business. Yeah.
Exactly that. Thank you. Thank you for those kind words. But I think of myself as the conductor. The work is done by yourselves. I'm just hopefully raising the flag for safeguarding. So
thank you very much, Jane. Councillor Corwick.
Thanks. Thank you for that. Just at the end, you mentioned contacts that would have been there. Is that the same as the contacts at the end of? Or
It should be in the supplementary.
Yes, that's for people to raise a safeguarding concerns. The little thing I have here is that slightly more
if there is more in the information that would have been available, could you make that available to us?
What I had on here was just a link about completing a safeguarding referral form online, but the phone number will get you there. That's the basic thing, but there are other ways of raising the concern.
Thank you very much. Thank you, Jane. So if we move on to agenda item number 10, I'm so sorry, Sian, I think we've got not very long, which is Healthwatch Reports, Mental Health in York, a progress review, mental health, what good should look like. If we take 10 minutes, we'll just take my report as read, as long as everyone's happy with that as the last item.
Okay. Sorry. So I've got some questions about the addition to the PCN.
Okay.
It's after your report. Pharmaceutical needs assessment.
Okay, that's fine.
Okay.
Okay. Okay, Sian, do you want to?
Yes. Thank you, Chair, and I hope I won't take up too much of everyone's time, but I just wanted to begin by reminding everyone of the role of Local Health Watch. So currently we exist to listen to people's experiences of health and social care and to make sure that these are heard by those who buy and deliver services. We are a very small team with a matching small budget and an enormous remit facing a slightly uncertain future, like many of our colleagues in health and care, but we believe what we do is vital. So we provide an information, advice and signposting service for anyone trying to navigate health and care services in the city. We undertake lots of engagement activities supported by community partners like York Explore and other community venues. And we work through trusted partners like York Mind, York Carers Centre, Age UK York, MySite, York Disability Rights Forum, just to name a few. We use everything we hear to shape the work we do and identify areas for further exploration. We then share what we hear through our reports. It's important, I think, to say that although these are often described as research, we make no claims that these are representative of everybody's use of services. Alongside wider initiatives in health and social care, we deliberately try to reach out to hear from people who feel that they're less well served by existing services and structures. Our reports are focused on trying to share those experiences and give voice to those who feel voiceless in the system. Our aims in completing these particular pieces of work were to review current experiences through the recommendations of our 2023 report about mental health and to explore further opportunities for future improvements. It is clear from the feedback we received that many of the concerns expressed remain. I am mindful, though, of how these reports will land with staff, particularly those working within the mental health system, at what is already a really challenging time for them. We know that those who reach out to us are often those whose experiences raise concern. I have no doubt, though, that there are excellent people in our mental health system providing great support every day that people haven't told us about. I am sure for many, helping people improve their mental well-being is a vocation that they give their all to. I know reading these reports would be really difficult for many of those people. But from our conversations, I think it is clear that there is a really strong appetite for us collectively to keep building on the transformative work that Connecting Our City has been doing, build on the support offered through wider partners, including the voluntary and community sector, who are very willing to keep being involved in what we do, and to expand the offer of mental health support in primary care through our GP practices. We'd like to say a massive thank you to Rachel Maskell MP for working with us to encourage more people to share their experiences and to get together with us to explore what better might feel like for them. And we'd love to thank everybody who spoke to us about their experiences and their ideas and their hopes for the future. There are no specific recommendations in these reports. They reflect on the recommendations in our previous report, and we believe those are still valid. We really welcome the commitment that's already been made to discuss these reports at the next mental health partnership with colleagues, and we hope that they can support the work being done there to continue the transformation of local mental health services.
thanks to everyone who's contributed to these reports, because there's some really tricky stuff that people have said in there as well. Naomi, did you want to?
Yes, thank you, Chair. So I think what I would want to start with is echoing what Sian's expressed, in that the content is difficult to hear. And I would start by saying that we're truly sorry for any individual that has a poor experience of our services and is disappointed, or doesn't feel that the needs are being met. So that's the starting point. And secondly, that we're really grateful to Healthwatch and our other partners in terms of the insights and the feedback that we receive. We can never stop listening to how people receive our services and their experience of it if we're going to move forward with the transformation and make things better for people, which is why we're here. I think it's important to share the focus that we've got around the York system. I was previously working here. I'm delighted to be back supporting York services, and Alison Smith, our new Chief Executive, who joined us in September, has spent more time, I would suggest, in York as part of her introduction to the organisation, and has been working in partnership with Rachel Maskell, responding to those complaints individually. And she spent time with people directly to understand their stories, to hear them, and so we can listen and move forward. I think the innovations and the improvements we've got planned in York and in other places around the community transformation, working really closely with social care, with VCSE partners, that is the key to changing the experience of people who need our services, and expanding, making sure that we've got the broader access. We do have a number of, we've got the hubs, which I'm sure you're all well sighted on, and we are taking an opportunity this year to look at how we maximise that resource, the things we've got in our York Access team. We want to make that a better experience alongside the community hubs, alongside our colleagues working in primary care as well. So we do have plans, and we've got ambitions to develop those services. I also thankfully had the opportunity before we started the meeting to catch up with Sian, and we will be doing joint work with Healthwatch and getting that lived experience for us. I just wanted to give that confidence to the board.
Thank you very much for that. Sarah, did you want to come in?
Yes, thank you. And again, thanks to Healthwatch for bringing the report, and thank you to those individuals who've shared their experiences. Like several items tonight, again, we've identified that there's lots of work for us to do. And I think in the earlier item on neighbourhoods, there was reference to the very positive existing models in York, and mental health hubs was one of those. And certainly when I came to York, I was really, really blown away, I think, by the strength of the Connecting Our City partnership. And it is a real partnership that has worked together and invested really significantly in terms of time and effort to co-produce those models. And we're getting there. We've got 2 hubs with ambitions and funding for a third. There's much more for us to do that's above and beyond the hubs, which is about thinking about how we deliver a really community-based integrated model of mental health that's got a sustainable footing. In fact, Naomi and I met last week. We were having those discussions about things like the crisis hub and our social care approved mental health practitioners and professionals, and how we might work better together and improve the resilience over what was quite small teams actually in the York patch. So again, it is difficult to hear, and we absolutely recognise there's a lot of improvement for us all to do, and we need to work together to do that. So I think it's the theme of the night really, which is where are we working together already, and where can we start to strengthen that? And the role of people with lived experience of mental ill health in our peer support workers and voluntary sector colleagues is really integral to that model as well. Thank you.
Thank you, Sarah. Sarah, did you want to?
It's probably a bit of a echo, I think, of the previous comments, but I mean, I read both reports with interest, obviously, and kind of seeing thinking about some of the key themes that are persisting, and for me, it really is around that team, around the person that could have the real potential to kind of make the key difference here, because there was a lot about services, but actually there was an awful lot about
kind of approaches and communication again. So I think that what we've heard, that theme that's kind of been through this meeting, and equally with the safeguarding item, the team around the person and moving away from a referral-based model to a relational-based model where actually we're supporting teams to do the right thing for people, because people know what the right thing is to do, but time and time again, statutory services sometimes prevent people from doing the right thing. So I think there's something for us to take in terms of the learning. And as Shana said, there is long-standing trust with organisations such as Healthwatch, and we need to be taking the kind of that strength into then the models. And I think the neighbourhood health policy will allow us to do that. That is an all age, physical and mental health, all people, all residents through the life course. So it gives us the opportunity, I think, to bake in the mental health hubs as the model. I think just finally, we don't always help. So speaking from an NHS perspective, we don't always help services move to new models of working. We expect providers to continue to work to existing, perhaps traditional models, but also, somehow on top of that, start to work in new ways. And we have a responsibility, I think, to bring all of that together to actually sustainably commission a new model that actually we want to see for our residents. So that's something that obviously the ICB and myself are supporting. Thank you.
Thank you. There seems to be real commitment as well across the board for neighbourhood and joint working. Thank you very much. So if we do move on to agenda item 11, which is my chair's report, I think Councillor Runciman has indicated she... Pardon? Annex A? Which ones are?
Page 223 and 224.
Got it. Thank you very much. Yep.
Okay.
Yes.
We'll be quick. I have had concerns expressed to me, which Peter won't be surprised at, about the loss of the 100-hour pharmacy hours for Westfield Ward, which you see in the second paragraph on 224, and the lack of access to pharmacy services on Saturday afternoons and Sunday. And I wondered if you might comment on that.
Okay. Absolutely comment on that. I think the loss of pharmacy is it's terrible. It's a sad thing. People who work, people with small children, people need out of hours pharmacy time, which is why we have put this PNA in, and it's public and it's out there. Really sadly, it doesn't mean we can force someone to open a pharmacy there, and it means that if there is something that if an application comes in, we will look at it. It will be looked at really favourably, but unfortunately, that's all that can be done at the moment. But yeah, I absolutely agree with you, Councillor Runciman. It is a loss. Yeah.
And yeah, from my perspective, we've done what we can as a board. I mean, but for those not in the know, pharmacies are independent businesses. What this statement that you have in front of you does is, as we published it as a board and signed off by the chair, if a pharmacy wants to open in this area, it has to go through quite a significant process to do so. And the evidence they look to is this statement. So if a contractor would like to open a pharmacy, the statement demonstrates a need, therefore that you're likely to be approved. Unfortunately, it doesn't produce that contractor on site to do that. That essentially is part of the way that pharmacy is set up in this country. We've done what we can as a board, I guess, is the reassurance.
Thank you. Sian, did you indicate that you'd like to say something?
No, I was just going to agree with Councillor Runciman that people have contacted us to raise their concerns about the impact this has on families living in that area. And it is concerning. It is a shame that there is limited opportunity for us to do anything directly about it, but fingers crossed somebody somewhere is listening and thinks, do you know, I'd love to run a pharmacy.
There's more and more services you can use pharmacy for. I think it's a real shame. Yeah. Okay. Councillor Colwick.
Just to say, Chair, this isn't limited to one area of the city. This is a citywide issue. We could be asking questions about Clifton, could be asking questions about Weldrake. It is a very, very real concern for the city.
Yeah. Thank you. Councillor Colwick. Councillor Webb.
Yeah, I think just to finish out, I mean, Clifton, as well noted, Councillor Myers and Councillor Wells have been banging the drum in Clifton for quite a while now. it does beg the question, while we have essentially a privatised system here that is based on, can a shop operate profitably, right? That limits what you can do. And the rules are very clear. And Peter's been very clear about what we can do and what we have done, which has been proactive, and this has been put forward proactively. I just think we need to be really careful about what is being implied here. I think it's very clear that the Health and Wellbeing Board is really not happy about this and is trying to do what we can, which is what has been done. We can continue to do that, but actually, until legislation changes, we are where we are. It's not the right place, but, we are where we are.
Sarah, sorry, Sarah, first.
Beat you to it. Yeah, I was just going to reflect on that. I mean, obviously, the Integrated Care Board commissions pharmacy services, and certainly myself, Peter, we've been back and forth around this in terms and ensuring that we are sort of doing everything possible, really, in terms of following. It's quite a rules-based system. It's very prescriptive in terms of what you can and can't do. And I think, it seems to me that the Health and Wellbeing Board has done everything it can to be able to influence. And I think it's now in a position to, as we've said, potentially fall more favourably, but then you're waiting for the market to respond. You are waiting for commercial providers to respond. So it's a waiting game to some extent on that basis. But just wanted to kind of sort of really.
Well, let's finish on a positive, which is that Clifton, we did the same thing. It's taken a very long time. We demonstrated the need in Clifton. A contractor has come forward and been appointed for Clifton. I can't give a date when that will open, but that process has gone through. So it does help to do these things.
Okay. Thank you very much, everyone.